OsteoBites is a weekly osteosarcoma webinar and podcast presented by MIB Agents. This week, we're talking with Dr. John Healey, Chief of Orthopaedic Surgery at Memorial Sloan Kettering Cancer Center, MIB Agents board member, and MIB Agents scientific advisory team member. Our panelists today are Lauren Raymer and Andrew Bisaga, both OsteoWarriors and MIB junior board members, Amanda Levine, OsteoWarrior and patient advocate, and MIB Agents Programs Chief, Liz Vallejo. I'm your host, Ann Graham, President of MIB Agents. Welcome to OsteoBites, everybody. Summer is here, and so is my husband's birthday, so my OsteoBite of the day is a cupcake. I hope you have your snacks too. We are honored today to have Dr. John Healey with us, who is the Chief of the Orthopedic Service at Memorial Sloan Kettering Cancer Center. He's a brilliant, amazing, lovely human being and surgeon. He's also on MIB Agents Board of Directors and on our scientific advisory team. Our panelists this week are super cool too. Two of them are also OsteoWarriors and are also MIB Agents junior board members, Lauren Raymer and Andrew Bisaga. MIB Agents Program Chief, Liz Vallejo is here, and I'm your host, Ann Graham, also an OsteoWarrior and MIB Agents President. MIB Agents makes it better, MIB for kids with osteosarcoma. Our mission, our life, our purpose is to make it better for kids with osteosarcoma. We do this through direct patient and family support by bringing together the physician, researcher, and patient community in the spirit of collaboration, and by funding meaningful osteosarcoma-specific research. We have over 200 volunteers that help us do this, including our dedicated medical researcher community that helps make it all happen, including our guest, Dr. Healey. So Dr. Healey, would you get us started by introducing yourself, please?
My name's John Healey, and I'm the Chief of Orthopedic Surgery at Memorial Sloan Kettering Cancer Center, and I live for this. This is really one of the great opportunities to see and to meet you all here, even by Zoom this afternoon, and I'm privileged to do so and glad that you've carved out the time, and hopefully will make it of interest and worthwhile for you, and to be with the wonderful panelists whom I have met before and am delighted to spend time with again, and of course our president and fearless leader, Graham. So it's she's just a superstar, and so we're really privileged to be able to work with her. And I'm going to start with two things: with the resurgence of COVID around the country, where you all are, and as things are slightly better in New York City, just remember to use your sanitizer and wash your hands and wear your mask. And you'll meet this guy again later on in the presentation. But take care of yourself, and so you can't say it enough. And my daughter, who's in Texas with predisposing condition from chemotherapy, needs to take care of herself, and you all do too. And so that's probably more important than anything else I have to say today. But with that, we'll go through and meet the other panelists, please.
Hi, everyone. I'm Lauren. As Ann said, I am an OsteoWarrior. So back in 2017, I was diagnosed with osteosarcoma. I went through chemotherapy, the regular rigmarole for 9 months, and then finished up in March of 2018, and actually was, I relapsed with a second osteo, but I've been cancer-free ever since. And also, my brother Brent was a patient of Dr. Healey's. So Mr. Healey is near and dear to us. He had osteosarcoma back in 2011 and unfortunately passed away in 2017. So I'm excited to be here. And my OsteoBites for today is some lovely chocolate.
I'm Andrew Bisaga. I'm an OsteoWarrior, and I was diagnosed with osteosarcoma about 3 years ago. I was about 12. I went through the whole, chemo thing, and then I was okay. So, 98% necrosis, and it was all gone, and now I'm just trying to make it better for everybody else.
Hi, I'm Liz Vallejo. I am MIB's programs manager. So if any of the programs that you hear about through MIB you would like more information on, I am the person that you should email, and I'd love to get you set up. My son Ian was diagnosed with osteosarcoma in 2015. And for my OsteoBite, I'm trying to go healthier, unlike you ladies there. And I've got almonds here because the chocolate is just calling my name. So on to you, Dr. Healey.
Great. So I'm going to be talking about precision surgery today, and also to put it in context of other aspects of precision medicine that is so much the rage and the buzzword of the day. First, a few disclosures. I'm a consultant for Stryker and for our drug company, Daiichi Sankyo. None of the prostheses or any elements I'm going to discuss are related to those things. I'm an editor of a journal and a board member of the Musculoskeletal Transplant Foundation and of MIB, as Ann introduced me. And elephants are real interesting in the osteosarcoma world, as you know from Dr. Schiffman's and P53 work, and we'll talk about that. But my element is going to be talking about how we modulate margin of resection, among other things, and how to adjust that to get the best and what we need, rather than just modify chemotherapy based on histologic response or other things. So it's what I would call tailoring the surgery rather than just the chemotherapy. Precision medicine can come in the form of biologic aspects, or I'll be on the other side talking more about anatomic aspects. And in each case, you can use targeted therapy. In the biologic, it's targeting based on drugs. In the anatomic, it's targeting based on surgery. And again, on the biologic side, things are exploding. It's everybody really the rage, and how DNA sequencing and other targeting approaches have just skyrocketed. But I think it's helpful to remember that 25 years ago, and literally the cover boy, cover girl for Science magazine was a P53 molecule. And so this was the most important genetic change in cancer, and that was celebrated 27 years ago. So we've made great progress, but we haven't yet cracked that nut. So, so the genetics and precision medicine along those lines were great, but at that time they said the cure was right around the corner. And that was 1993, Christmas Eve. And as mentioned, Dr. Schiffman's spectacular work highlighting the abundance of P53 copy number in elephants and reduced sarcoma and other cancer development, I think is fascinating work and is going to be very fruitful. But the aspect of precision medicine based on those things is as yet largely an undelivered promissory note, and what continues to be the backbone of the treatment is surgery and accurate use of the knife. The trouble is, how do you decide where to cut? And assessing treatment response is really one of the great things. If we wait until, like Andrew's assessment, 98% necrosis, that's wonderful, but you find that out 2 weeks after the surgery, 2 months or more after the start of chemotherapy. And so it would be nice to know up front, perhaps by genetics we can learn that, but in the meanwhile, we're constrained in using imaging to try and judge it. And this is just one slide from a paper looking at the response to chemotherapy judged by PET scan, where it was really bright up here at the beginning, receded, and by the just after, or at the time of surgery, rather, it had faded greatly. And so if you have more than the 60% reduction in the PET scan intensity, that this correlates with a very good histologic response. And ultimately, as you are aware, we grade the histologic response. And that's important in terms of the local disease, but what we're trying to do is not only that, but correlate it to what's happening systemically. And that's good, but it's imperfect. That correlation runs a correlation coefficient of about 0.8, which as you extrapolate that, you square it, so it amounts to 0.64, which is good for a D in school. And so if D were a satisfactory grade, none of us would be where we are today. So, assessing the response to chemo is wonderful, but that comes a little bit too late, and it's not that accurate, and we need better measures. Non-invasive techniques like PET scan are helpful, but in the end, good judgment and good surgery is of critical importance. Now, furthermore, even though the paradigm is using preoperative chemotherapy, particularly in pediatric group, it's not mandatory. And it's also important to remember this classic paper through the pediatric oncology group, where patients were randomized to receive chemotherapy preoperatively or not, or just receive it post-op. And I think it's instructive to look at those data. That's here for 5-year event-free survival. If you had immediate surgery, it was 69%. Neoadjuvant, 61%. Limb salvage in 55% who had immediate surgery, only half of those who had neoadjuvant therapy. And surgical complications were the same between the groups. So even though this is our paradigm, and I do it most every time, we shouldn't be a slave to it, and it shouldn't be our religion. We need to look at the data very carefully, and on top of which, pre-op chemo response has never been ultimately shown to correlate in a way that allows us to alter the chemo and change that response. So I think one of the earlier OsteoBite segments by Matt had to do with immediate surgery. And so he touched on some of these points, but I wanted to go into a little more detail on that history to drive home the point. But we do grade the necrosis, and this is a standard system that came from Memorial Hospital. Our data, in essence, if you collate it, if you had more than 90% necrosis, there was 90% cure. These are durable, 10-year disease-free survival numbers, so that I think they're real. 279 high-grade localized tumors. But next most important thing right here is that even if you have lousy necrosis, less than 50%, grade 1 necrosis, where everybody's greatly disappointed, well, more than half the people still are disease-free and cured. And so you have tripled the survival based on that chemotherapy, and that has to do back to what I said about the correlation between the local disease and systemic disease, and that's only worth a D in school. So don't get discouraged. Even if you have only mediocre necrosis, you're still tripling the cure rate because you're eliminating that distant microscopic metastatic disease. So, again, even though I'm talking mostly about surgery, the chemo is fundamental. In terms of surgery, the debate is always limb salvage versus amputation, and ultimately, how close are you willing to come to the tumor? And the farther away you are, the more confident that you've gotten all the cancer. The closer you come, well, you save some more normal tissue, and that's lovely, but you're tempting fate from satellite microscopic tumor cells that could be in the region. And so you're balancing out what other tissues you're sacrificing and how much you need to get the cancer. So in essence, 100% of operations end up being tailored to the individual patient, to the local anatomy, to the disease characteristics, and what you've assessed in terms of the chemo response by PET scan or in our studies. The most important thing is when I put out my hand, used to before COVID, now I put out my elbow, you know, say hello to the patient and ask her how she feels. And the response to chemotherapy and how fast the pain is relieved is the highest correlate to what the response to chemo is going to be. And so that encourages me, that emboldens me to come closer to the tumor. If it took several weeks, if it took this to the second round of chemo for that pain to subside, well, then usually the response isn't quite as good, and it makes me a little more cautious. And so I'm going to take a little extra tissue to make sure that I've gotten it all. So, so you can do high-tech things like PET scan, or low-tech things like asking the patient, you know, how she feels. So here I'm going to talk about targeted surgery and precision surgery. So we'll talk about that, margin of resection, reconstructive methods, and then I'm going to talk some about custom prostheses and the difficulties and the regulatory aspects that hold us back and limit things there. So the classic surgery is with what's called a wide margin. This is cutting through normal tissue in all directions, and it enables us to do these days safely limb-sparing operations in 85% of cases. Amputation remains important, rotationplasty occasionally very important. And the other overriding principle is to remember is just because you can do something doesn't mean you should do something, and using judgment in making that decision and is extremely important. And one of the aspects that's not emphasized enough of what can happen during that preoperative chemotherapy is that I get to know the patient. I know the person, I know their family, I try to understand what motivates them, what's their priority, not what's my priority here. And so I have the time to do that in a little more relaxed fashion. So, you know, what I don't want is somebody to show up on my door, well, they're ready for surgery now, have the chemotherapist tell me, go ahead. No, I want to have taken the opportunity to really get to know the patient and figure out what's important and how to make those judgments. It's essential to avoid local recurrence. Local recurrence, you can still overcome, but it's extremely difficult. And this is shown by data from many institutions. Here it's from St. Jude's, and you look at that survival curve after local recurrence, and this repetitively plays out around the world. 10% of people survive, not 0, but only 10. So, you know, don't give up if you're in that situation, but it's better if we can be aggressive and appropriately get rid of the cancer to start with and not have to try and clean up afterwards. Many people, my colleagues, say that limb salvage is the same as amputation, and they base this on a classic series of papers from the Musculoskeletal Tumor Society. And Bruce Rugraff from Indiana is the lead author on these. And this is the curve that comes from that. And so the great thing about that study is it's dealing with just the distal femur. So one location, one area, you know, not the pelvis, Lauren's brother's tumor, or other people who have it in the humerus. It's just single location. And comparing amputation and limb salvage and hip disarticulation in a large group of patients from members throughout the organization. And the conclusion was that this was the same. However, not to be too boring about the whole thing, but statistical analysis enables you to say with confidence, or how confident you are in that result. And in all of medicine, we want 80% confidence in something that's called beta error, or it has to be low. Of you're willing to overlook an important difference only 20% of the time. This is where what's called the power of the analysis is for the Musculoskeletal Tumor Society study that showed equivalence of limb salvage and amputation. This is what it ought to be. So instead of 227 patients, it needed to be 1,300 patients. So this is grossly underpowered. And this is the fundamental basis for what I and all of my colleagues, what we make our reputation on, saving limbs. That's what my foundation is about, saving limbs. But it's based on somewhat tenuous data. And it's important to always keep that in mind. If the response to chemo isn't great, if people aren't doing well, if you're not sure you can get a good margin, if you're tempting local recurrence, you're better off with an amputation. And so, but that said, 85% of cases we're able to save the limb. So you just can't blindly go in one direction or another. You need to tailor it to the circumstances. And a hard look at the data shows that. But I would contend very few people and very few of my colleagues really understand that or have looked at it, and how poor the power is of the analysis of what we do. Fancy prostheses, however, cost as little as $48,000. Some of them are in about the $65,000 category now. And you need one every year or two. You might want to drive around in a Mercedes a little better than having a sea leg. You can get a lot farther and a lot faster. So in any event, the cost effectiveness is something to keep in mind as well. Strategy for the surgeons: identify the best curative option. Try to accommodate the learn what the patient wants, what the family's goals are, and then within a shared decision-making approach, decide what's going to be the best strategy. Now, the system that we use to judge the type of surgery that's done is cutting into the tumor is intralesional. Marginal is cutting around just on the edge through what's called the inflammatory pseudocapsule. Wide excision is going through normal tissue. Radical is taking out the whole muscle and bone compartment. And sometimes people divide these into adequate or inadequate. But what's important is what Dr. Enneking originally said in defining this. You need to have an effective adjuvant. Not just any adjuvant, not just lousy chemotherapy, not just chemo light. You need effective chemotherapy. And if you get that, well, then limb sparing is possible. Then you're allowed to back down and do something like wide or marginal surgery. Next question, how much is enough? What is the metric? And there are several that have been offered. And so I'll discuss a couple of them and what the implications have been for that. These are data from major centers in the United States, from centers that train fellows. So there are 10 places in the United States that train fellows, and the panel met my fellow Del McLaughlin here earlier as we were getting set up. But so these data are from the leading centers in the United States. So, but here you go. Local recurrence, 20%. Well, that's not adequate in my mind. So big number of patients. Fairly modern series. This is not ancient history. This is not for the pre-chemo era. This is recent. And they went through what the different methods were. whether you're using the American Joint Commission system, the Musculoskeletal Tumor Society system, or just a strict measuring of distance, whether it's 1 millimeter, 2 millimeters away, or whether there's cancer right at the surface. And it makes a difference how wide your margin is. Here's a series from one of the other major cancer centers in the United States, where they train fellows. Bottom line, 14% local recurrence rate. That's, you know, I'd like to be in the 86%, not in the 14%. So, and again, this is correlated to what the extent of the margin is. You come closer to the tumor, you have a higher chance of recurrence. And 14% is too much in my book. Our data, it was 3.7% local recurrence. So these are published. It's not just my opinion. These are facts. And I think the data speak. So you want a good margin. You want to be far away from the tumor. This is from the major center in England, United Kingdom, Lee Jays, again, highlighting the importance of how many millimeters you are away from that tumor. And so the surgeon doesn't have microscopic vision. You can't see all of those cells, but you have to weigh all those factors, from everything from how the patient's doing, how much the swelling has subsided, how tender the mass is, what your imaging studies show, and the like. And so they concluded that there was a relationship between the amount of necrosis. This is in England, biggest study. They have 4 centers, 2 big ones and 2 little ones, that treat all the cancers in the whole country. If you have good response to chemotherapy and a wide margin, they have the lowest local recurrence rate. Less good chemotherapy, less good margin, here 19 or 20 times the rate of local recurrence. So that interplay between the chemotherapy and the surgery is critical. And so this is shown around the world in the hands of the top surgeons. From Italy, Rizzoli showed the same thing, big number of cases, 365, and how they classify it is a wide margin or less than a wide margin here on top, and whether they had good, fair, or poor response to chemotherapy. And so the way I look at this is just like a street light, red, yellow, or green. And if you're in the green category, you have a green light, you can go ahead. This is the relative risk of getting local recurrence. And so good chemo, good wide margin, low risk of local recurrence. Bad response to chemo, narrow margin, inadequate, 46 times the rate of local recurrence. So that interplay between response to chemotherapy and how precise your surgery is makes a big difference. And so, you know, what's interesting is what happens in this yellow category. So in green, limb salvage is great. In red, limb salvage is a disaster. In yellow, what do you do? And so for all of you who are driving behind the wheel, when you come up to a street light and it's yellow, what do? Do you step on the gas and go through and try to get across that light? Or do you hit the brake and slow down and wait and be cautious? And so the same thing, same analogy applies to surgery. If you've got mediocre response that you've assessed beforehand, do you forge ahead, force the issue, try to get that narrow margin, or do you say, hey, I'm going to broaden this, I'm going to step back and take a little bit more tissue to make sure I get it all and we don't end up with local recurrence. So this is the crux of curing the cancer from a surgical standpoint. Now, there's a bunch of fancy ways that we've gone to try and help with that in order to save more normal tissue and make sure we've gotten the cancer out. And so I've done a variety of experiments, and this is one. Making custom jigs beforehand enables you to make an accurate cut to excise the tumor and save, in this case, the joints in the lower end of the femur. And so there's certain technology and advanced work that can help us. There are a variety of other things now with so-called navigation, intraoperative navigation, so you can have three-dimensional view of where you're cutting. But these are great. They help. They can preserve normal tissue, but they're also seductive. And they entice you to come closer to the tumor and save more things. And so once again, you've got to be very careful, avoid that seduction and making mistakes of going into the tumor. Moving on to some of the reconstructive aspects after you've cured the cancer. Massive allografts aren't used as often anymore, but this is one of my teachers, Henry Mankin at Mass General Hospital, and he was really the person who popularized allografts in the United States and the world and did more than anybody else. And so I always, hats off to him. He really inspired me, and, you know, I aspire to his greatness. We'll see. However, what they found, and what my other teacher, Dr. Lane here in New York, and I first reported, was if you're giving chemotherapy, the allograft doesn't do so well. It doesn't heal as well, it disintegrates more, and this is the survival curve from the Mass General large series, and how with those chemo responses, they didn't do as well. If you didn't have chemo, the allograft does real well. So in any event, the role of allografts has diminished, but there are a couple of great things about them still. And number one is you can replace the joint surface with it. And that's important if it allows you to save the other side of the joint. For example, replace the proximal tibia in a young child where the major growth plate is in the distal femur. You can allow that to grow. The child can achieve their more normal height. And even if the allograft fails later, at least you have solved the limb length inequality problem. The critical aspect now is keeping soft tissue. So it allows, in this case, this is the upper part of the humerus, and it allows you to save the rotator cuff and repair that. So in a sense, I don't care about the bone. I can replace that with metal. But the soft tissue, I don't have a good replacement for. That hasn't been invented in the world. The attachment, that soft tissue to the bone, to recreate. And so here it comes naturally. You know, God did that for me, and I just need to be smart enough to take advantage of it. So the combo, the allograft prosthetic composite, remains valuable in the hip. These grafts are fairly available. You know, within a week, I can usually get one. That's wonderful. Whereas, and we'll get to custom prostheses, but that takes 2 months to manufacture now. Here I can get a bone, I can carve it in the operating room, I can adjust it. Is it as good? Well, if it has soft tissue attachment, yes. If it doesn't, at least it's readily available. Sometimes you have to adapt it to the circumstance. Construction needs to be creative, and when you have only small amounts of bone that remain, it's very difficult to get fixation and to build on. So often, amount of bone at the end of the bone, you've got to replace the whole joint. So one of the challenges is how to save that, how to conserve that, and these are some examples of ways that I've invented and tried. So I'll just call your attention to this case over on the far right, where there's a very short remaining bone. This was a man who, and he's been out in literally in public and in the newspaper and said TV shows and Hard Knocks on ESPN is about him, one of our patients. And so and he's given me permission to discuss his case, but he was 17 years, had 3 failed allografts, and was going to have his whole hip replaced with a total femur replacement. With this custom device that I had developed, he was able to go back, and he, a football coach in the National Football League for many years, and was able to run around with this, couldn't quite keep up with his players, but enough so that they were both impressed by what he could do and intimidated that he was tougher than they ever thought they were. So, and you OsteoWarriors out there qualify. And so here's one of your cohort. And so these are variations on that theme where you're dealing with very short remaining segments. And so how you have to customize it, work with what you've got, be creative, use new metallurgy and prosthetic designs. If you're able to do it biologically and avoid cement, that's tremendous, which we try to do, and these are just some examples of that. This is one of the more striking ones. A patient was infected, knee replacement was removed. They had a spacer, which was horrible. Her femur was angulated 70 degrees. It was a disaster. But 11 years ago, I took all of that out and replaced this, and she's walking and, you know, as a professional and, you know, not needing pain medicine or things. And so being creative, even working with small amounts of bone and saving it, that's precision surgery in the reconstructive mode. And then we've taken it to the extreme of dealing with these really short segments, and that's a very stressful mechanical situation. The engineering here is horrible, but I put in conjunction with that a vascularized fibula. So you have biologic reconstruction to supplement the metal that's immediately giving you firm fixation. And so the two of them, instead of having a 1-lane highway, you have a 2-lane highway. And so it's much more effective and long-term. And so this is approaching 11 years. You'll see this patient in a picture shortly. This is work from another center using similar kinds of techniques of, you know, short segment, uncemented fixation, saving the joint surface. This is area of using hydroxyapatite coating that induces bone to grow into that area to give a good, long-lasting, strong fixation here in the tibia for this person. Challenges dealing with limb length inequality are very severe in young children in particular. We talked about rotation plasty, which is one option to always remember. But here, I'm going to briefly mention the various advances in lengthening prostheses. And so some older versions have been done. They can work well, but they have mechanical problems. And so this person stripped her gears, and the thing, she had been lengthened out that long, and it shortened acutely. So there were mechanical problems to these. So it would be wonderful. We strive for them to last a lifetime, but they're in very highly stressed situations, and no device is actually made to hold up. So it means most people end up facing revision surgeries at some point. The most recent advance is using the Stanmore so-called grower prosthesis, magnetic expansion of the limb. And these are being done increasingly, not so many in the United States. There are major obstacles to importation of these devices and engineering aspects, but they are compelling. If you can lengthen the limb in a non-invasive way, that's tremendous. So these are another elements that enable us to do precision and targeted surgical therapy. And you can lengthen all kinds of places, not just the distal femur. Here it's the proximal femur. Custom modular devices can be done. This was unfortunately a case where it wasn't known, thought to be a cancer when in fact it was, and then a major resection was required a custom manufactured modular implant to replace and resect that. So you need to be very creative to handle some of these problems. There's another one. This person was going to lose his arm. And while that's okay to cure a cancer, it's undesirable. But very creative approaches, lengthening prosthesis for the humerus, modern elements of what's called a reverse shoulder, and biologic fixation in these areas enable you to do things. And again, using the templates, intraoperative navigation, matching exactly what you cut out with what's been fabricated to fit into that space can be tremendous. Increasingly, we are doing, this is work from my partner, Dan Prince, who presented a couple of years ago at the MIB conference on bone transport. And so using, again, the bits of remaining bone and dragging them through the tissues sequentially, a millimeter a day, can reconstitute this entire bone, as you see in this sequence here. So very creative, innovative strategies for limb salvage. And here's another example, recreating the whole tibia. And some of just documenting the results, which is important when you're doing these fancy things. This is the patient I showed earlier, the combination of implant and vascularized fibula, the two-lane highway. And so he wrote a book about this. They have a TV show, and it's on Thursday night on NBC, so you can tune in tonight if you'd like, but it's a regular show, Council of Dads. There was a lot of poetic license taken with the story, but he's, approaching 12 years disease-free. Here he is with his young twins, and the guy who plays me in the story he's a nice guy, and it's good, so I'm happy with that. So it's a shameless plug for the TV show. So the goal here is try to combine targeted therapies on the biologic area, on the surgical area, and moving toward biologic reconstructions. So that's the precision surgery. Now, all right, I'll try to move it along and not take too much more of your time. But we have big problems with custom prostheses, dealing with Congress and with the FDA, and potentially MIB can be important here. So hopefully this won't be too boring. Back in 1976, medical devices started to be regulated. Congress got involved in 2009. They had the FDA a custom act that came along. You have to meet 5 prongs to justify this. Custom devices were exempted from some of the regulations. There are subdivisions for compassionate use or humanitarian devices that I'm not going to go into. Some interesting litigation on the topics. Do custom contact lenses qualify as the same as for these prostheses you've seen for me? And they know different rules for contact lenses. Different companies have tried. The government has shut them down. It went to court. The 11th Circuit has opined on these things. It was all very confusing. The guidance was elusive. Nobody understood it. People complained. Congress is up in arms. And in 2012 came through with this rule that you can make 5, count them, 5 of any kind of device for the entire country per year. 5. Well, osteosarcoma is rare, but we need more than 5 for each location for the whole country. And so this is where MIB and others can, talking to your congressman and lobbying the FDA can make a difference. Your voters, they listen to you more than they listen to me, and certainly more than they listen to the companies.
Well, there's lots of us, so we should have lunch. Let's do lunch.
Yeah,
we gotta chat.
Absolutely.
We gotta chat about our next big job.
And the reason the FDA doesn't trust the companies is they've tried to do things about how sell different custom prostheses to men and women, even though 90% of the prostheses are fit for each, and they had very narrow rules on this. So I'm going to skip this other to move to the other questions, but there has been some progress, but it's still very strict and difficult. They've driven companies out of the business, so it takes 2 months, and so we can't get a custom prosthesis made in time for you to finish your induction chemotherapy and have it ready for your surgery. So both you and I are up the creek. So this 5 rule continues. So the approach is not user-friendly to anybody. It may protect the public, which is what the FDA thinks, but it's less responsive to the individual patient and the doctor. And so anybody will have this number up. If you want to contact somebody, this is the guideline from the FDA and the address, and you have to leave, right at the bottom is the docket number, right? And highlight that. And my last plug was for this guy from the allograft and from the Transplant Foundation, and the donors, the families of people who've generously donated bone are desperate to hear from you and the recipients and how their generous donation has changed lives and made the donation worthwhile. And so anybody who is stuck at home on lockdown and can't go anywhere, write a letter, send it to the Transplant Foundation, and they forward it to some of the families of donors who are greatly appreciative. I'm impassioned about this topic, and thank you for your time.
That's actually why we love you, because you're impassioned about this project, about what you do and your patients and how you do it. And thank you.
I thought it was super interesting the way that you were trying to find that correct balance of taking margins, but also recognizing that the more you take, the more it affects the patient. And finding that balance, I think that can also relate to the balance of that harshness of the attack, especially with the chemotherapy, balanced with getting that reoccurrence, but also the side effects of that harshness of the therapy or the surgery. Because I think about how Brent, he did go through some extremely harsh chemotherapy, and then a couple of years later ended up getting AML. So what are your thoughts on finding that balance?
Translates in lots of different ways. For example, he had breakdown of his wound, and we had to operate on that and clean that up and to get that stabilized to enable him to get the intense chemotherapy. So these two aspects of surgery and chemo do dovetail and work together. I was never in the military. We often use these military analogies somewhat glibly. You know, the war on cancer, established by President Nixon in 1971. And so I talk about that. But, you know, I go to war to win and not to look good in my uniform. I like looking good, but that's not the
eye.
Um, um, I think there are occasions when backing off is important, to give people a breather. But sometimes you have to be cruel to be kind. And if you give people too much of a breather, or a breather every time, it's a problem. And I'll use the analogy of Ewing sarcoma, where the distinction is clearer. When we intensified therapy every 2 weeks instead of every 3 weeks, the success rate increased. So it's tangible, it's real. It beat the crap out of the patients, but they were cured. When we went to a 5-drug and transplant situation, then a high number got this AML, just like Brent. So we initially had over 90% cure, and then lost 20% of those people nearly with secondary leukemia. So the problem is you don't know that until later. Although now we know that. And so now we're much more cautious about pushing those specific drugs. And, you know, Brent is a martyr. I use that word deliberately and carefully. I use words carefully. You know, we wish you were here, but thank him for those sacrifices. And so it makes it better for the next person, which is why you're all here today.
Right. Okay, we have a question from Dr. Belzarina.
How are you?
Cecilia, hello.
How's it going? So I have 2 quick questions. One is, do you go back for an R1 margin? And the other one is, do you change the treatment protocol if there's a fracture? And if you believe in that concept of a contained hematoma?
Fracture is much more common, up to 20% in telangiectatic type of tumors that don't have much matrix. Osteoblastic tumors, only 2% fracture. And that's because there's more matrix, it's more stable and all. So, so those high fracture risk in telangiectatic, they actually have the best response to chemotherapy. So it's paradoxical sometimes. Containment of hematoma, that's a very big problem. So a displaced fracture bleeds a lot, and I think you need to cut out the whole compartment. At UCLA, they don't cut out the whole compartment, but they radiate it, and they think that the rest of the compartment can be sterilized by radiation. So I think one way or another, you have to sterilize the compartment, either surgically by cutting it out or supplementing with unusual treatment like radiation.
Okay, thank you so much.
Talk to you later.
We have another question from Janet Panic. Go ahead, Janet.
Hi, can you hear me?
Yep.
Yes, perfect.
Okay, great. So my question was, given the need for wide margins to reduce the risk for recurrence, do you feel the removal of more tissue adversely impacts functional outcomes for patients with limb salvage?
It does. And both acutely and in long-term survival of the implants, for example. And so we were the first ones to study this in distal femur replacements. And so if you're taking more than 2 of the 4 quadriceps, the survivorship of the implant goes down. If you excise more than 40% of the distal femur, the survivorship of the implant goes down. So you pay a price. And so back to, you know, Lauren's question in a different way, you know, where's the trade-off between those things? And here to answer both yours and Dr. Belzarina's question a little bit further, of our 279 patients that were in that study I presented earlier, 2 of them had positive margins. And interestingly, neither of those patients recurred, partly because we ended up reaming out the bone and cementing in a prosthesis. So they were so there's still a lot we don't understand about it, but anything that we can control, I want to control. Oh, and the other point that actually is very important is getting soft tissue coverage. So if you're taking a wider margin, there's a higher chance of an infection. And so then a higher chance of needing plastic surgery to cover the tissue and to avoid infection. So for every action, there's a price to pay for it. And you know, I'll give one more example. My first fellow, Alan Yasko, was the chief at MD Anderson afterwards. And so their approach for tibial tumors was to do needle biopsy and not excise the tract and not have to do muscle flaps. They had a low infection rate as a result, but 12% local recurrence rate. We had a higher infection rate, but low local recurrence rate because we excised the biopsy tract and did the muscle flap. So whatever you do, you know, pick your poison perhaps, but I'd rather deal with a muscle flap or infection than recurrent cancer.
Yeah. Yeah, you know, and I hear sort of anecdotally in the community that they're not able to rehab after limb salvage and speculate as to, you know, how much, that maybe there was more muscle removed than they had anticipated, et cetera. So, you know, just sort of as a follow-up question to you, have you ever, or, you know, counseled with a patient that they may want to choose an amputation based on how much of the tissue, you know, how much clean margins you can get? Are those decisions, I guess my question is, are those decisions ever made during surgery?
Once in my career, but I made the decision, but I closed the wound and discussed it with the patient afterwards and went back and did a second surgery. So I've never had to amputate or made that decision intraoperatively. But I can envision a situation, particularly if there's a vascular injury or something, that you would have to do that. But so never say never, but I do everything to avoid that. You know, and there are situations where this, I think the two prime locations, in the distal femur around the ankle, you decide the reconstructions are lousy in general, and the below-knee amputations are generally good, and so I'll favor amputation over limb preservation. Not always, again, you have to be selective. And the other location is in the pelvis, where there are three important structures: sciatic nerve, femoral nerve, and acetabulum. And if all three are good, limb salvage. If 2 out of 3 are okay, limb salvage. If 1 out of 3 is okay, your function's lousy, but some patients still want to keep their leg. If all 3 are affected, amputation is absolutely necessary. So again, this is tailoring it to the anatomic realities.
Still 2 questions. One of them is mine.
I can stay all night, as you know.
I know you can. You can outlast me for sure. I'll be asleep on the waiting room couch. Okay, so there's a question about something you said earlier about the 10% survival rate. And so the question is about, can you elaborate on that? And I remember what you had said there and what you were talking about, but I'd rather have you answer it since you're sitting here.
Local recurrence can be because of bad response to chemotherapy, bad surgery, or both, or just bad luck. And it's hard to distinguish sometimes between those things. If there is local recurrence, you should take care of it. Sometimes you can still save a limb. Sometimes it's multifocal and needs to have an amputation. sometimes additional different chemotherapy is helpful. Dr. Belzarina's question earlier. But if you look at all comers, so it could be any of those explanations, the fact is only 10% of people are long-term survivors. So you give it the old college try and not throw in the sponge, and you can still save lives and can still often save limbs. But so you shouldn't give up. And even if someone doesn't achieve long-term survivorship, they can have significant value to prolonged good quality, reasonable quality survivorship, and that should not be dismissed.
Great. Okay, my question was back to the bone donation. Can you, so, I mean, I guess I hadn't thought about it. I remember going into, I remember being like in the pre-op space, and your fellow at the time was Adam. Remember Adam? So he came in and he was
Johns Hopkins now. Yeah.
Is he? So, so he was measuring my leg, and he said, you know what, I have the perfect tendon for you. And I'm like, what do you mean? And he goes, yeah, I have a tendon in the freezer, and I think it's the right length. And I was going, you have tendon in the freezer? What do you mean? And he goes, well, you're not going to be able to keep your tendon. This is going to be your new tendon. I was like, so I have donor tendon? It just struck me as so fascinating. And then he explained further, it's actually a really great thing to have donor tendon because it keeps really well in the freezer. Anyway, it was a great conversation to me, you know, quite diverting before surgery. But I, you know, my own ignorance, forgive it, but here it is. I mean, I have a giant allograft, as you know, and of course the bone to do the allograft came from somewhere. I just hadn't thought about it. I knew about the tendon because, you know, because there was that moment, but do people who have donated bone, do their families know, was this an end of life thing and they donated their body to science? How does that work?
It varies somewhat, but usually they're trauma victims or drowning victims. And in a situation where it's not someone who's been in the ICU for a long time and has infections and things. The grafts are very carefully curated, and there's careful microbiologic assessment. In other words, making sure that they don't have HIV or hepatitis or other things. And in the it's been since 1984 nationally, since disease was transmitted through one of these that we know of. So, so the Transplant Foundation and the American Tissue Banks have done a spectacular job in managing that. And so I think it's safe and acceptable, and it's great, and there's no substitute in many cases. But then these people donate their bodies for transplants, and how it works is that the bone and other soft tissues do not have active blood supply anymore. So your bone is dead as a doornail. When organs are harvested, they take the most important ones first that need to have blood pulsing through them. So they take the heart, they take the lungs, they take the liver, and those get whisked off. And that's what you see on TV shows and read about. Bone and skin are the last, and they don't have active blood in them. They are processed through the tissue bank, and literally the blood is flushed out of them, so it's clean. You don't have to match the blood type. You don't have to match tissue type that you do for kidney transplant, for example. And that's why you don't have to take immunosuppressive drugs, because they don't invoke that same type of immune reaction to be suppressed. So that's one of the beauties of it. And they sit in the freezer. And again, dead as a doornail, but they perk up right away. You know, it's like Encino Man who comes out of the out of the ice cube, and it's good.
Yeah. Okay, that's fascinating.
And they don't need all the special food groups to
Yeah.
survive like Encino Man.
Okay, so I know that sounded like kind of a morose conversation, but I mean, that's a really fascinating one. And I have to say, now that I've thought about it, and you have bereaved families who have served us as a community who are receiving this bone, I'll write a thank you note, like 100%. And so do share that information, and we'll share it on MIB, and put it out there. Ask anybody who wants to write, here's where you can write to. You have my letter. It's coming.
Right.
Like that's a really meaningful thing to do at MIB.
Oh, and I've seen some of the letters back from the families,
Yeah.
and the names are not individually connected, so
Yeah.
it's you know, anonymized, as long as you want it to be that way. But but they're touching how it really made a difference to them.
Yeah. Wow. We partner with Childhood Cancer Project and CCTDI in legacy autopsy for kids who have passed from osteosarcoma, and same thing. I mean, it's wildly, it's such a gift to all of us. It's such a gift to all of us, and in a way, they're martyrs too, right? Because they're sacrificing so much, and giving the rest of us a gift to learn from their suffering. It's such a brilliant thing, and I'm so grateful. Okay, we're so over time. And you've been really gracious with your time, and so I don't want to push it, but thank you. I'm super grateful. By the way, Amanda Levine has been very naughty and has joined us anyway, even though.
Hey, yeah, I see her name's popped up here.
Yeah. Hi, Amanda.
Hi.
So,
hope you're feeling better.
Yeah, we're with you, Amanda. Hope you're feeling good.
I wouldn't miss you for the world.
Amanda, you're the best.
Yeah,
Okay.
God bless you.
Amen. God bless you, Amanda.
Thank you.
For he has
You know,
left
if people have individual questions, they can send them to me, and I'll do my best to respond and answer them.
Okay, sounds good. If that's the case, please send them to info@mibagents.org, and we'll pass them on. We've had a couple of comments here saying we need a whole special webinar called Ask Dr. Healey, where we can pepper you with questions.
We can do that, you know, and I'm happy to do that and zip the lip, let you guys talk. And,
I'll tell you what, if I had a Ask Dr. Healey line on my phone, you'd block me at some point and be like, today my leg feels a blank. Anyway, okay. So thank you. And I have to say that next week we're taking our first break from OsteoBites. It's 4th of July weekend. So you can use that time to go back and listen to all 12 previous OsteoBite sessions. What else would you do on 4th of July weekend? You can have a burger or a hot dog and do it. They're on podcast and YouTube. When we come back on July 9th, we're really excited, and we're greatly anticipating speaking with Dr. Katie Janeway. She's the Associate Professor of Pediatrics at Harvard Medical School, where she's a senior physician. She's also at Dana-Farber Cancer Center, where she's the Blood Disorders Center Director. And she's also at Dana-Farber Cancer Institute, where she is in clinical genomics. She has very exciting news to share about a clinical trial for osteosarcoma, which is funded by the Osteosarcoma Institute, the same people who generously provide the osteosarcoma hotline for patients everywhere. So please register for that on our website, mibagents.org. blue bar at the top, hit OsteoBites. Finally, if you have not downloaded or received your OsteoBites book or your osteosarcoma from our family to yours book, please do. It's a free download on mibagents.org, or you can get a hard copy for $5 shipping and handling. If your institution would like more than 5 copies, please let us know. We just ask that you cover shipping. And osteosarcoma patients everywhere love this book. It's just over 100 pages and really great information. By the way, it was written by panelist Liz Vallejo, and our scientific advisors also chimed in on it: Dr. Healey, Dr. Alana Church, Dr. Mateo Trucco, Maureen Smart, who is a licensed clinical social worker and OsteoWarrior mom, is a contributor, as was Jim Riley, and me. So that's the book. Please let us know if you'd like a copy. And oh, by the way, it's being translated into Chinese and Spanish as we speak, and we'll be ready at any time now. So we're anxiously awaiting that. And we have a great distribution center in China, and that's thanks to an OsteoWarrior dad because of Max. So, and Spanish has a whole other story there, so we'll cover that another time. But in the meantime, thank you for joining us today. Of course, thanks to our guest, Dr. Healey, our panelists, Liz, Lauren, Andrew, and Amanda, as usual. Stay safe, everyone. Wear your mask, please, please, please. And if MIB agents can be of help to you, please let us know. Together we make it better for everyone who suffers from osteosarcoma. Register now for next week's OsteoBites, when Dr. Katie Janeway, Associate Professor of Pediatrics and Senior Physician at Harvard Medical School and Center Director at Dana-Farber, Boston Children's Cancer Center and Blood Disorders, will be here. She will be talking about a new clinical trial that was funded by Osteosarcoma Institute. Sign up on our YouTube channel for early viewing each week of new videos and access to the entire library of OsteoBites. For OsteoBites podcast, listen wherever you get your podcasts. Until then, please help make it better for kids with osteosarcoma. Visit our website at mibagents.org.